Hello and welcome. Today we're diving into a rare and complex congenital condition known as the bladder exstrophy-epispadias complex, or BEC for short. This condition involves defects affecting the abdominal wall, bladder, and genitalia, and requires a comprehensive understanding for effective management. Join us as we explore its causes, effects, diagnosis, and treatment. So, what causes BEC? While the exact etiology isn't fully understood, it's believed to be a multifactorial condition involving a combination of genetic and environmental influences during early fetal development. Specifically, it is thought to result from a failure of the cloacal membrane to properly fuse and close during the 4th week of gestation. Although research is ongoing, no specific gene has been definitively linked as a sole cause, making it challenging to pinpoint specific triggers. Let's talk about pathophysiology. In simple terms, BEC arises from a disruption in the normal development of the lower abdominal wall and genitourinary system. Normally, the abdominal wall muscles and skin fuse during fetal development, enclosing the bladder within the pelvis. In exstrophy, this fusion fails to occur. The bladder then develops outside the body, exposed on the abdominal wall. Epispadias, a condition often associated with exstrophy, occurs when the urethra opens on the upper surface of the penis in males, or the clitoris in females, instead of at the tip. The degree of severity varies, but the fundamental issue is incomplete closure and malformation of these structures. BEC is a rare condition. Bladder exstrophy, the most common form, occurs in approximately 1 in 40,000 live births. Epispadias without exstrophy is even rarer. There doesn't appear to be a significant difference in prevalence among different ethnic groups, but studies are limited due to the rarity of the condition. The diagnosis is often made prenatally through ultrasound, allowing for planning and preparation for postnatal management. The signs and symptoms of BEC are usually quite apparent at birth. With bladder exstrophy, the most striking feature is the exposed bladder on the lower abdominal wall. Urine constantly leaks from the exposed bladder. Other associated findings can include separation of the pubic bones, shortened penis in males, and malformation of the clitoris and labia in females. Individuals with epispadias without exstrophy may have urinary incontinence and difficulties with sexual function later in life. Diagnosis of BEC usually starts with a prenatal ultrasound, which can detect bladder exstrophy. After birth, physical examination readily confirms the diagnosis. Further investigations such as X-rays and ultrasounds of the kidneys and ureters are performed to evaluate the upper urinary tract for any associated abnormalities. Cystoscopy, an examination of the bladder with a small camera, might be used later to assess bladder capacity and function. BEC isn't strictly categorized into distinct types, but rather exists on a spectrum of severity. At the milder end, we have isolated epispadias, where only the urethra is affected. Then, there is classic bladder exstrophy, which involves the exposed bladder and separation of the pubic bones. The most severe form is cloacal exstrophy, a complex condition involving exstrophy of both the bladder and the rectum, often associated with omphalocele and imperforate anus. The treatment approach is tailored to the specific type and severity of the condition. The primary goal of treatment is to achieve urinary continence, preserve renal function, and reconstruct the genitalia for optimal function and appearance. Initial management involves protecting the exposed bladder with sterile dressings to prevent infection and trauma. Surgical reconstruction is typically performed in stages. The first stage involves closure of the bladder and abdominal wall, along with repair of the epispadias. Further surgeries may be necessary to achieve urinary continence, such as bladder neck reconstruction or augmentation cystoplasty, which enlarges the bladder using intestinal tissue. Lifelong follow-up is essential to monitor kidney function and address any complications that may arise. Currently, there's no known way to prevent BEC, given its complex and multifactorial etiology. Genetic counseling may be offered to families who have a history of the condition, although the risk of recurrence is generally low. Prenatal screening and early detection through ultrasound play a crucial role in preparing families and medical teams for the challenges ahead. The prognosis for individuals with BEC has significantly improved with advancements in surgical techniques and postoperative care. With successful reconstruction, many individuals can achieve urinary continence and lead relatively normal lives. However, lifelong monitoring of kidney function is essential, as some individuals may develop complications such as urinary tract infections or renal insufficiency. Recent research focuses on refining surgical techniques, improving long-term outcomes, and understanding the genetic factors involved. The development of tissue engineering and regenerative medicine offers promising avenues for future treatment strategies, potentially leading to the creation of functional bladder tissue for reconstruction.